distance between us both. So I don't know how far we'll be able to do as a workshop, but I promise you that the promise and the aim, objective of the session is that I keep you awake for the next 1.5 years. That will be my prime objective. Whatever gets into it is an additional bonus for me. At the outset, I would like to thank faculty and the organizing committee of the Tagore Medical College of this MedTadCon. Thank you for inviting me as a faculty. Right, it gives me great pleasure to stand before you, and straight away, without adding anything further, we would go to the workshop. Now, this is predominantly designed for an undergraduate students. So, if any postgraduate students are there, please forgive me. This is just a brushing of the basics. So, I believe that this would be more meaningful to you than talking about high funda stuff. Okay. Now, I believe there's a hand mic given to you. Who's got the hand mic? Who's got the hand mic? Hand. I request the first one at that corner. Who's got it? Yeah, fine. Keep that with you. Now, I believe that the very basis of we all standing here and talking about ECG is because of this great gentleman called Ito Wen. He started his work on ECG late back in 1896-94. Now, this gentleman was the first one who could think about such an amazing aspect, like without putting a head into your chest, try to find out what's happening in the heart. This is the first time that we could look into the function of the heart, how it is doing, by any method without actually looking at it. So, first non-invasive evaluation of the heart was thought and processed by this great man, and who was awarded the Nobel Prize in 1924. Now, this is something that we all would like to listen, or this is overlapped with the sound, but what we see is some wave patterns. This is the very essence of life. A patient is admitted to the hospital or to the ICU, this is what we would expect to see, and this is the very basis of life, and this is evidence of life. So, that's how important ECG is to everybody. Now, this is how a picturoscopic representation of how a heart would contract. Is this right? The first one? Is this contraction right? No. Very nice. Pass it on. So, this is how it should happen. You should have not the whole heart contracting. You need to have different points, different parts of the heart contracting. And for that to contract, we need some depolarization wave to take place and help the muscles of the atrium and the ventricles contract separately. And for this to happen in a very synchronized way, we have something called the electrical circuit of the heart. Okay. So, this is what you should remember. It is not a single pump. It is a huge, excellent pump that keeps beating till you breathe your last. And it doesn't pump at the same time. Each chamber beats separately, and each chamber needs to beat separately. And then one after the other, it synchronously needs to keep beating continuously. And this is done by the electrical circuit. And the very normal genesis of ECG is these electrical circuits, or the passage of current through the circuits, when it is mapped, when it gets connected to the chest wall, and you map them by placing electrodes over the chest wall, and which comes as waveforms on the ECG paper, that is what we tell as ECG. So, basically ECG is a representation of the electrical activity that takes place in the heart. Now, this is some basic anatomy that we all will know: the left atrium, the right ventricle, the left ventricle, the pulmonic valve, and the SVC coming into the right atrium. And then you take the cut section, you have the right atrium, the tricuspid valve, the right ventricle, the left atrium, and you can see the nice muscular left ventricle also. And this is the conducting system: the SA node, then you have the AV node, the bundle of His, the left bundle, and the right bundle. This is some basic anatomy that is basically required for us to understand what ECG is. Now, as you see in this diagram, the SA node is the one that discharges the impulse, and this gets conducted to the atrium, and there is a speed breaker, which is the AV node, and then after that the impulses slow down, and then it conducts to the bundle of His and the left and the right bundle, and then the ventricles are depolarized. Okay, so this is synchronization. Now, for the SA node to start generating the impulse, the atrium also depolarizes. We have some bundles, also called the anterior, middle, and posterior bundles, and from the right atrium to the left atrium, we have the bundle of Bachmann also, which conducts impulses faster to the left atrium. Now, to prevent the direct conduction of impulses from the atrium to the ventricles, we have this fibrous strings which insulates the atrium from the ventricle. Okay? If an impulse that generates at the atrium goes straight into the ventricle, then there is no synchronization. Right? So, you need some insulation between the atrium and the ventricle, and the fibrous string does this job. And it is composed of the aortic valve, the tricuspid valve, the mitral valve, and the central fibrous body. The AV node is located just above the tricuspid valve. It is in direct continuity with the atrial myocardium and continues lower as a bundle of His, which passes through the fibrous trigone and the membranous intraventricular septum and divides into the right bundle branch and the left bundle branch, and the left bundle branch further divides into anterior and posterior fascicle. Now, this is the SA node. Now, this SA node, it contains 2 to 3 separate clusters, and each cluster is containing about 5,000 cells. And these cells spontaneously discharge. Okay? And once the threshold reaches a certain level, then the channels open and the sodium and calcium ions gets conducted. And then an action potential is generated and that is propagated. Okay? So, this is the spark that ignites the whole electrical activity in the heart. So, the SA node does that. Now, this igniting ability is not only confined to the SA node, but also the AV node also can do that. The bundle of His can do that. The Purkinje fibers can do that. Even sometimes the myocardium also can do that. But what we need to know that this, as we come down from the SA node, the AV node, bundle of His, the branches, the Purkinje fibers and the muscle, the rate at which they fire slows down. So, SA node being the dominant pacemaker sets the rate of the heart. Okay? Not that others don't function, they are also capable of functioning. But what sets the heart rate is because SA node sets it, because it is a dominant pacemaker, because it beats at a much more faster heart rate. Okay? And the other one gets overlapped. So, if at all by any chance if a SA node doesn't function, then the lower down the other components of the conducting system like the AV node can start performing as the pacemaker, but at a lower rate. If below the AV node also something happens, then the Purkinje fibers take over as the pacemaker function. So, God has produced heart in such a wonderful way that despite so many problems, it can still continue to work for the benefit of human and to keep the breath going. Now, this is how a representation of the normal atrial depolarization takes place. At one swing, the right atrium first and the left atrium, and then you have the atrium, and then the ventricle also depolarized. The point that you need to understand is, in the atrium the depolarization is a single stroke from the right to the left, whereas in the ventricle it conducts down to the septum by the bundle of the right bundle and the left bundle, and then simultaneously the right and the ventricle depolarizes. Okay, that's the difference. So, there first is an atrium is a single dipole, here is multiple dipoles that are responsible for the depolarization of the ventricle. Now, the repolarization takes place in the same way that the depolarization takes place, and then the ventricles also depolarize, but in the opposite way. As it goes up, it comes back down. Okay? So, that is the difference between these two. Now, this is what I taught was little bit of basic anatomy and physiology. Based on this, we go further. Now, this is how a ECG machine looked like way back in the early 19th centuries. Right? The gentleman out there is immersing his hand in salt solution, the hands and the legs. This helped the conductance, and that's how the ECG machine looked way back in early 19th centuries. Now, this is how an ECG machine looked like: sleek, smart, handsome and beautiful, and very accurate and efficient. Now, this is what a normal ECG looks like. Okay? Now, the next one with the mic. Would you like to comment on this ECG? Don't talk about waves and all. Is there something that you would like to look at the ECG before you start something? Would you like to know something? There are something written there in the left corner, in the middle and all that. Pardon da? Be louder. Keep your mouth. Okay. Next. Keep passing the mic. Very nice. Very well aptly said. What do you mean by standardization? Okay, wonderful. Next. No, you can tell.
That should be minimum of 2 boxes.
Okay. Anything else? Okay. Now I will save you the trouble. Now this is called standardization. Now when you read an ECG, what you should know is the ECG is done, or the machine is run with a current of 1 millivolt, that is equal to 10 millimeter in height. That's what my friend said as a rectangle mark. And it is run, the paper is run at a speed of 25 millimeter per second. These are absolutely essential points that you need to understand. And you need to know that the previous ECG had something called name, age, sex, date and time. This is also very, very pertinent. So before reading and interpreting an ECG, you need to know these basic standardization points first before you start reading what an ECG looks like. Now, if you look at the left hand corner, this one, this denotes a current that we use. So we use a 1 millivolt current that is equal to 10 millimeter. The rectangle looks like a 2 boxes each. This is an ECG paper. Before I go into that, it contains large boxes and small boxes. Okay, the large box is made of 5 small boxes. When the ECG is run at 25 millimeter per second, each small box current corresponds to 40 millisecond, and each large box corresponds to 200 millisecond. Okay, that's a speed. And the current that we use is 1 millivolt current, and that is equal to 10 millimeter in height. Okay, this is something which is very basic and you need to understand. Understand, every small box corresponds to 40 millisecond and every large box corresponds to 200 millisecond, and the ECG is run at 25 millimeter per second, and the current that we use is 1 millivolt current. Okay, now what is the importance of the current that we use? Now look at the ECG at the top corner. Look at the waves crossing over the ECG paper. Okay, so now we will have difficulty in interpreting the ECGs. So what we can do is, instead of this normal 10 millimeter which is equal to 1 millivolt, we do what is called half standardization. We decrease the current, and so that you bring out the whole complexes inside the paper. That's the advantage that we have. You understand? Or if you feel that the complexes are small, then you can use something in the C which is called double standardization. We increase a 2 millivolt current, and then you increase the size and height of the QRS complexes. You understand what I'm trying to say? So that is the advantage we have in the ECG machine. Now next, the speed at which it is run. Now look at this. The first half of the ECG shows it is run at 50 millimeter per second. So what will happen when it's run at 50 millimeter per second? All the complexes will be very widely spaced. We'll get an apparent bradycardia. So when you have an ECG where the complexes are very close by, we're not able to clearly make out the waves and the segments, you can increase the speed and get it wide apart and look into the waves and the segments. Okay, at the same time, when it is run at 12.5 millimeter second, they form much more closer. Okay, so inadvertently, if you look at an ECG and not look at the speed at which it is run, if it is marked and run as 12.5 millimeter per second, then you will have a wrong interpretation of a tachycardia. And if it is run at 50 millimeter per second, you will get a wrong interpretation of a bradycardia. You understand? So that is the importance of the speed. Now this is one more. Next point. The last point I told you before, name, age and sex. After that is time is very important. Now this patient came with an ECG at XY time to the casualty with chest pain. Nothing significantly was there. There were some changes that were suspicious of an acute ongoing coronary event. So the same ECG taken after about 25 minutes, you can see nicely developed ST segment elevation, which we'll come to that later, suggests you of a myocardial infarction. So unless you have a previous ECG, you can't interpret the new ECG. You understand? So these are ECGs are dynamic things that happens in the emergency. Right? Somebody comes to you with chest pain, he's got some changes which we are not sure whether it was old one or new one, but if he's got an ECG taken 6 months back, then you can compare these two ECGs and tell this is new changes. You understand? So your name, age, sex and time and date is very important to interpret the sequence of events as the ECG is done at various points of time. I hope you understand the importance. Now, after the standardization, now coming to the appreciation of the waves. In the heart, there is simultaneously occurring electrical forces which are directed anteriorly, posteriorly, left, right and center. However, these forces are of unequal magnitude because of the unequal myocardial mass in the chambers of the heart. As I told you, left ventricle is the maximum, got the big muscle mass, whereas the right ventricle much less, right atrium and left atrium much more less. So the electrical forces generated by these chambers varies with respect to the chambers from which they originate. Okay? Therefore, the signal recorded by the electrode will reflect the direction of uncancelled electrical forces and is directly proportional to the underlying muscle mass. In simple terms, you have a thick muscle, you have a nice tall QRS complexes or nice voltage complexes. You understand? If you have a very thin myocardium or the muscle mass is less, then you will have low voltage complexes. As simple as that. Now, another one, basic physics. Now, if you have an electrical current traveling towards from the negative to the positive, towards the positive electrode, you will get a nice positive wave. Okay? If it is traveling away from the electrode, then you will get what? A negative wave. Okay? If it is going equiphasic or perpendicular to that, then you will get a biphasic wave. You understand what I am trying to say? So, what we do in an ECG is, we put so many electrodes in various parts. Okay? Now, these are all called limb leads. These are called bipolar limb leads. So, this is what Ethoven did and invented. These leads were developed by William Ethoven to represent an equilateral triangle where the heart assumed to be a symmetrical sphere located in the center of the triangle. Okay? So, this is what he did. So, he put 3 leads, lead 1, lead 2 and lead 3. The lead 1, the right arm is the negative pole and the left arm is the positive pole. Lead 2, the right arm is negative and the left leg is positive. And lead 3, left arm is negative and the left leg is positive. So, he put 3 leads, okay, and he tried to match or try to find out what is the electrical axis of the heart with respect to these electrodes. You understand what I am trying to say? So, theoretically, the heart should be in line with the lead 2, okay, that is 60 degree. Any change or pathological component that happens in the heart may tilt the electrical axis to one side or the other side. Okay? So, instead of lead 2 being positive, you can have more positivity in lead 1 or lead 3. That means it is pathological. You understand what I am trying to say? So, that is what Ethoven tried to find out. He put different electrodes and tried to map all those electrodes against the normal electrical activity or the axis of the heart. And these leads were formed. Now, based on that, furthermore, we evolved over it and we got something called augmented unipolar limb leads, where the AVL is perpendicular to lead 1, AVF, AVL is perpendicular to lead 2 and AVR is perpendicular to lead 3. So, now we got 6 more arrows or 6 more leads where we can put. This allows more precise localization of electrical forces in the frontal plane. When these leads are superimposed on the triaxial system, a hexaxial system is created with 12 equal angles of 30 degree. So, lead 1 is 0, lead AVL is minus 30, lead 2 is 60, lead 3 is 120, AVF is 90 and AVR is 150. Okay? These are the angles that these leads represent. Okay? Try to pay more attention because the very interpretation of the ECG depends upon all these angles and the leads. Now, this is how it looks like. Okay? So, you find the lead 1 with respect to the electrical activity or axis of the heart, there is a more positive and a slight negative. If you look at lead 2, which is almost in line with the electrical axis of the heart, you get the maximum positivity. Lead 3 also slightly closer to lead 2, so you will also have maximum positivity. Look at AVR, the last one down here. Okay, this will tell it is almost against the normal electrical axis of the heart. So, you will have a purely negative wave. You understand? So, these waves are created so that we map these ECG patterns with respect to the electrical axis of the heart and find out abnormalities. Okay? Now, we didn't stop with this. Now, this is what it looks like. You see, if you look at this diagram, the maximum positivity with respect to lead 2, that is 60 degree. And if you take at EVR, which is or AVR, which is almost against the normal electrical flow, so you get a negative wave. You understand what I am trying to say? Okay. Now, we didn't stop with that. We went one step further, which is called unipolar chest leads. This was described by Wilson. So, we put leads like this V1, V2, V3, V4, V5 and V6. Now, these are considered as semi-direct leads in the limb leads as indirect leads because of the distance from the heart. These are much more closer. You can put the lead straight on the chest, whereas limb leads are there in the limbs. So, these were called as semi-direct leads, very close to the heart. So, these measured the electrical activity much more precisely than your limb leads. You understand? So, this is how you put the limb leads, chest leads V1, V2, V3, V4, V5 and V6. Okay. Now, combining this both, this is what we get. Now, the limb leads are representation of the heart in the vertical plane. Okay, it's on the coronal plane. Okay, whereas the chest leads V1 to V6 are representation of the heart in the transverse plane or the horizontal plane. You understand what I'm trying to say? So the limb leads are representation along the vertical, whereas the chest leads are representation of the heart in the horizontal or transverse plane. Combining these two, what we get is lead 1 and AVL represents high lateral part of the heart. The V1 and V2 represents septum of the heart. V3 and V4 represents anterior part of the left ventricle. V5 and V6 forms the apex or the low lateral part of the left ventricle. You understand? Right? Please understand, this is your basis. You understand, then only we can go further. 2-3 AVF represents the inferior part of the heart. Let's go through this once again. V1 and V2 is, I want you to be louder, septum. V3 and V4 is anterior. V5 and V6 is apical or low lateral. Lead 1 and AVL is high lateral. 2-3 AVF is louder, inferior. Okay, so get this right. Unless you get this right, we cannot proceed further. Okay, right. Now, ECG, we have something called, to make things much more simpler for you, we have something called 2 segments, 3 intervals and 4 waves. Okay, 2, 3, 4. 2 segments, 3 intervals and 4 waves. Now, the 2 segments are the PR segment, the ST segment. The 3 intervals are PR interval, QT interval and RR interval. And the 3 waves are P wave, QRS, T and U wave. Okay, the 2 segments are PR segment and ST segment. The 3 intervals are PR interval, QT interval and RR. What are the 4 waves? P wave, QRS, T and U wave. I hope that you all are awake still. Yes, can I hear a louder yes? Very soft it is. Okay, not bad. Let's get that improved next time. Okay, let's look at the P wave. What does the P wave denote? Now we went through the physiology of how the heart contracts, what is depolarization, what is repolarization, the SA node, the AV node, the bundle of His, Purkinje fibers, things like that. Okay. Now there are certain waves that happens in the ECG. Now we will try to focus on this wave and try to correlate with the electrical activity or the activities that takes place in the heart. Now first is the P wave. Anybody can tell me with the mic what is the P wave denotes?
Atrial depolarization.
Wonderful, wonderful, very nice. So this is atrial depolarization. Now look at the wave, look at the monitor. You can see the P wave that is forming in the ECG and correspondingly the electrical activity that sweeps across the right atrium and left atrium. Okay. Now if you could be much more intelligent and smart, you would find that the right atrium depolarization represents first half of the P wave and the left atrial depolarization represents the second half of the P wave. As simple as that. Now, a slow this thing. So this is the first half, the right atrial depolarization, and this is the second half of the P wave representing the left atrial depolarization. Indicates atrial depolarization, contraction of the atrium. Amplitude is not more than 2.5 millimeter. No notching or peaking normally. Normal duration is 120 millisecond and seen best in lead 2 and V1. The duration is louder. The one with the mic.
120 milliseconds.
That means how many small boxes? One small box is equal to what?
40
milliseconds. So it should be
3
not
boxes.
more than 3 boxes, 3 small boxes. Okay, fine. You are in tune with me. Now next we have this something called the PR segment. This component of the one represents the PR segment. Look at this. Now we have the atrium getting depolarized, and after the atrial depolarization, till the impulses reach the right bundle and left bundle, that is the PR segment. That represents the PR segment. Okay, look at the two pictures. You have atrial depolarization, then look at the fibers that gets conducted, the right bundle and the left bundle. After the atrial depolarization, the time taken between the completion of atrial depolarization and the beginning of ventricular repolarization represents PR segment. Okay, what is PR interval? Anybody with a mic? Come on, come on. Okay.
The time interval between P wave and QRS.
So PR interval in
And-
simple words indicates a time from when the wave is initiated at the SA node and till the ventricle starts depolarizing. Okay. So it is the duration of the time that takes from the SA for the impulse to start at the SA node and reach the ventricles in simple terms. Okay. So what is the normal duration? The normal duration is about 120 to 200 milliseconds. The one with the mic. That is equal to how many boxes? Equal to 3 to 5 boxes. Anything more than 5 boxes, it means PR interval prolongation. As simple as that. Okay. Indicates AV conduction time, beginning of the P wave to the beginning of the QRS. The normal range of the PR interval, that is the interval from the onset of the P wave to the onset of the QRS complex, is between 120 to 200 millisecond. In simple words, 3 boxes to 5 boxes. Okay, what is the QRS? Next. Fast.
The ventricular repolarization.
Ventricular repolarization?
Depolarization.
Depolarization or repolarization?
Depolarization.
Hello? Ventricular?
Repolarization.
Depolarization. Okay. So this is what happens. Okay. Now look at the diagram. Look at the ECG. The first one, the septum, then the mass, and then the base. Okay. That's how it represents. Okay. The QRS complex, Q wave is the first negative deflection without any preceding component. The R waves is the first positive component and may be preceded by a Q wave. The S wave is the negative component following the R wave. Okay. So first negative before the R wave is Q. First positive is called the R. And negative after the R is called S wave. And you can have an R dash wave also, which is a positive wave after the S wave. Okay. So please remember Q, R, S. R and R dash are positive waves. The Q and the S are the first and second negative waves. Okay. The normal duration between 60 to 100 milliseconds. The one with the last, with the mic. 70 to 100 millisecond corresponds to how many boxes?
2 to
2.5.
Yeah, 2 to 2.5 small boxes. Keep all this in mind. Okay, this is important as we start interpreting ECGs. Now this is what? The first one, the Q wave, indicates a septum getting depolarized from the left to right, and then you have the muscle mass predominantly, then the basis of the heart of the ventricles that gets depolarized last. Complete depolarization of ventricle 80 to 100 millisecond. That these characteristics of ventricle depolarization, that is sequence, vectorial direction, duration are reflected on the surface ECG by the QRS complex. The sequence of depolarization is first septum left to right, apex to the outflow tracts of both the ventricles, and base of the heart. What does this denote? ST segment. Next to the mic.
It is the time between completion of ventricular depolarization and atrial repolarization.
ST and T wave. This is the ST and the T. This is the ST and T.
After ventricular depolarization,
It represents the ventricular repolarization. As simple as that. Okay. So look at this once again. Now the initial part of the ST indicates early repolarization, and the T wave indicates late repolarization of the ventricles. As simple as that. The T wave indicates late ventricular repolarization, not more than 5 millimeter in amplitude in the standard leads and not more than 10 millimeter in the precordial leads, that's the chest leads, rounded and asymmetrical. The ST segments indicates early ventricular repolarization, not depressed more than 0.5 millimeter either in height or in depth, may be elevated slightly in some leads but not more than 1 millimeter. Now the question and the most interesting component of what we all see is a ST segment elevation or depression, which corresponds to acute coronary syndromes. So please pay attention to this. Now the ST segment is isoelectric with the normal isoelectric line of the heart. The isoelectric line is when no electrical forces or the voltage gradient is 0. Okay. This corresponds to the TP segment. Please understand, this is the TP segment. This is the reference point. This is the reference point. Based on this, you can tell whether ST is elevated, isoelectric or depressed. Get this point into you. Right? Your reference point is what? The one with the mic.
The one which helps to see if there's a pathology.
That's a TP segment. The reference isoelectric line is a TP segment, and you always compare the elevation and depression corresponding to the TP segment. Okay. Now look at this. So you have something called ST elevation. This is the TP segment, and you have ST elevation corresponding to the TP segment. Here this is the TP segment, and you have ST depression corresponding to the TP segment. Okay. This is very important. Please get this imbibed into you. Okay. The QT interval, next one. Measure from the onset of the QRS to the end of the T wave, represents both ventricle depolarization, repolarization. Normal duration is less than 460 millisecond. And the last wave is the U wave. The U wave occurs with or immediately after the downslope of the T wave. Short duration, best seen in V3 and V4. Low amplitude. U waves become more obvious when the heart rate is low, that is during bradycardias. Rarely seen when the heart rate is more than 100. It represents delayed repolarization of the Purkinje fibers. Okay, that is U wave. Several abnormal situations produce U wave, like hypokalemia, ischemia, use of anti-arrhythmic drugs, congenital long QT syndrome. Its presence has diagnostic and therapeutic implications. Okay, when you see U wave, it has got some therapeutic and diagnostic implications. And it is often sometimes merges with the T and sometimes complicates QT measurement. A small point to note in U wave is, when it is present, it indicates there's a problem, and that problem on resolution, the T waves gets resolved. Okay, so it has got definitely diagnostic implications. Okay. Now summarizing this, there are how many? 2 segments, 3 intervals, 4 waves. So we have this, and what do they represent? The 2 segments are PR segment and ST segment. PR segment, conduction from the AV node to the ventricles. In ST segment, early repolarization. Significance of ST segment, very important in acute coronary syndromes. The 3 intervals are the PR interval, the QT interval, and the RR interval. We talked about the PR interval. It is an interval from the origin of the impulse till it reaches the ventricle. Okay. Normal duration is 120 to 200 millisecond. Anything beyond that indicates there's a block in the conduction. The RR segment represents what? Which we didn't talk about. It talks about the heart rate. As simple as that. We talked about 4 waves. First wave is P wave, QRS, T and U. P wave indicates atrial depolarization. QRS indicates ventricular depolarization. T wave indicates late ventricular repolarization, and U wave indicates repolarization of Purkinje fibers. Okay. Now this is a thing that you need to understand. The normal values. P waves, the height is, the duration is less than 120 milliseconds, that is 3 small boxes. Amplitude, it is not taller than 2.5 millimeter. The PR interval is 120 to 200, that is 3 to 5 boxes. QRS duration is less than 100 millisecond, 2.5 boxes. T waves and the QT interval is 460 millisecond. Okay. Summarizing what we studied now. We started with anatomy, did a little bit of physiology, and we saw how ECG represents various activities of the heart. Okay. So remember, 2 segments, 3 intervals, 4, right. This is what we need to go further. Okay. Right. As an undergraduate or a house surgeon, there are 5 things you need to know in ECG. Basic things to start with. First is the rate, the rhythm, hypertrophy of the chambers, ischemia and infarction. This is where the whole workshop starts. What we studied till now is only basics, basic knowledge. So rate, rhythm, hypertrophy, ischemia and infarction. These are 5 things that we'll know. There's one more thing that I've got on another 10 slides. If time permits, we'll see that at later point of time, if time permits. Okay. Now this is the rate. Okay. The representation which we normally saw. Now one with the mic. What is the difference between the first one and the second one? Fast, fast, get up.
One is
One is
tachycardia and
Don't worry about the rate. See how it is going. Regular or irregular?
complex. The QRS complex is
First one is regular, second one is what?
irregular.
Okay. So you normally calculate the heart rate when the rhythm is regular. When you have a regular beat, you will be able to calculate easily. At your level, don't worry. When it is irregular, don't calculate. As simple as that. Okay. So the prerequisite for at your level to calculate heart rate is the rhythm should be regular. You should get a heartbeat on a regular interval. That's how you will be able to calculate the heart rate. That's very prerequisite at your level. Irregular heart rates also can be calculated, but don't worry about that at present for you. Okay. Next, the heart rate is calculated by 1500 divided by number of small boxes or 300 divided by number of large boxes. Okay. Now let me put it simple way. Right? If you have one box between the two RR interval, then it is 300 divided by 1. The heart rate is, please close your books. Listen to me. Close your books. Listen. Okay. So if it is one box between the two RR, then it is 300 by 1, which is 300. If there are two large boxes between the two RR interval, then it is 300 divided by 2, that is 150. If it is 3, then it is 300 divided by 3 is 100. If it is 4, it is 75. 5, it is 60. 6 is 50. 7 is 43. 8 is 38. And 9 is 33. Remember this. Now I'll make, so be clear. Mug this up once again. Okay. So if it is 6, it is 50. If it is 7, 43. If it is 8, 38. If it is 9, if it is 10, 30. Fair enough? Okay. Right. Next. Who is next on the line? Get up. Is this regular? Is it regular or not? Do you look at the rhythm strip? This is called the rhythm strip. Is it regular? Can you read the number of boxes between the two RR waves? I hope your eyesight is good, not bad as mine.
6.
6. So 1, 2, 3, 4, 5, 6. 300 divided by 6 is
50.
50. So that is 50. Next. Fast, fast, fast. Is it regular? Look at the last strip. How many boxes are there?
7 to 8.
8 boxes are there. You need to check your vision, ma. Let's say it's 8. 300 divided by 8, what did we say?
43.
43.
3.
30?
38, sorry.
8. So it is 300 divided by 8, it is 38. Next. Talk fast, fast. How many boxes?
7.
7. So 300 divided by 7 is?
40.
40?
3.
40?
43.
43. My goodness. Okay, next. Fast, fast. How much is it? Come on.
10.
10 boxes. So
30.
300 divided by 10 is?
30.
30. Very nice. Next. Fast, fast, fast. Get up.
2 box.
2 or 2.5?
2. 2 and down.
2.5. So now tell me, 300 divided by 2.5 is? Mathematics முடியலன்ட்டு தான இங்கே வந்திருக்கோம். இங்கே வந்து பாடா படுத்துறீங்களே. Come on. So it is 300 divided by 2.5 is 120. Next. Fast, fast. 1.5.
1.5.
Right. So what is it? It's around 200. Okay. So that's how you keep interpreting. Now one more if you want.
So 1.5.
1.5. Okay. Next. Once again, it's almost close to 1. So it is almost 300. Okay. So that's how you calculate. But what you need to understand is they should be regular. Okay. Then only this formula is applicable. So please understand RR interval. How many large boxes between the RR interval? If it is 5 boxes, it is 60. 6 boxes, it is 50. 7 boxes is 43. 8 boxes is 38. 9 boxes is 33. Okay, this is our representation. Okay, so you have a normal heartbeat, you have a bradycardia and tachycardia. When the heart rate is more than 100, it is called tachycardia. When the heart rate is less than 60, it is called bradycardia. That finishes the first chapter. Okay, next is rhythm. You are ready for it? Can I hear a louder yes? All of you are awake? Very nice. Okay, a normal sinus rhythm is defined there should be a P wave. That means impulse originates at the sinus node. Okay, so there should be a P wave, and each P wave should be followed by a QRS. Okay, and the PR interval should be consistently constant. That means the P and the QRS are married to each other. Okay, so that is called a sinus rhythm. That's called a sinus rhythm. Okay, now this is how it looks like. The P wave, the atrium gets depolarized, and then the AV node, the septum, and then the ventricles. Okay, consistently keeps happening. The P waves is formed, and then the QRS. So this is, what is this? Sinus rhythm. Okay, what is this? This is nothing but another example of a sinus rhythm. What do you see? If you look at the ECG, there is a P wave, there is a QRS. P and QRS are in harmony with each other or synchronized with each other. Okay, you can see the impulse originating at the SA node, getting conducted to the AV node, and then the ventricles. As simple as that. Pay attention. Now, what is this? Where is the rhythm? Where is the rhythm? You can see something circulating, right? This is where now the pacemaker is. Okay. Now what happens? From this pacemaker, it still goes, that is AV node, the bundle of his, and then from the center it goes to the right and the left. So what is the complexes that is there? QRS, still narrow complex. Okay. But the sinus node is not there here. So what is absent? P waves are absent. You understand? So you have a narrow complex. That means the impulse that is generated starts above the ventricle. Okay, but there is no P wave. So what does it mean? Sinus node is not the one that sets the rate. You understand? The impulses does not originate in the sinus node. So absence of P wave indicates sinus node is gone, knocked off. Okay, but still when it is narrow, that means it is above the ventricle. So that's why it is called supraventricular rhythm. You understand? Okay, now look at this. Now there is an impulse that is originating at the ventricles. Now look at the complexes. How is it? How is it different from this? This is broad. You understand? So when you have a broad complex, then it without a P wave, it indicates what? Where is the origin of impulse? Ventricles. Okay? If you have a narrow complex but no P wave, the origin is supraventricular. If you have a P wave and a narrow complex, it is sinus rhythm. You understand? So these are three things that you need to understand. One is a sinus rhythm, P wave followed by a QRS. Next is supraventricular rhythm, where you don't have any P waves but the complexes are narrow. That means it's originating above the ventricles. And the third one, you have a broad QRS complex without a P wave, that is called ventricular rhythm. You understand? So please understand, rhythm, we will proceed further and you will understand only when you know these three things. One is sinus rhythm, supraventricular rhythm, and ventricular rhythm. Fair enough? Shall we proceed? Can we get an S? Louder S? Okay, thank you. Right. So when you look at arrhythmias, you look at 3-4 things. Whether it is a sinus rhythm or not, that means P wave followed by the QRS. Whether it is narrow or broad complex, brady or tachy, regular rhythm or irregular rhythm. Okay. Now I will talk about certain things, please understand. We will concentrate on a sinus rhythm which is tachy and brady. We will talk about a supraventricular rhythm which is tachy and brady. We will talk about a ventricular rhythm which is tachy and brady. Fair enough? We will teach you 6 rhythms. Okay? Done? Can I hear a yes? Yes, sir. Very nice. Okay? Now, anybody who's for the mic? Get up, please. Look at the ECG strip. Is there a P wave?
No.
Yes.
Is there a Q wave, QRS wave?
Yes.
Is it preceded by a P wave?
Yes.
So if you look at all the complexes, a P wave and the QRS are close to each other, equal.
Yes.
So what is this rhythm?
Sinus rhythm.
Sinus rhythm. Now calculate the heart rate. 8. So 300 divided by 8 is what?
30.
38. So this is tachy or brady?
Brady.
Bradycardia. So this is a sinus rhythm plus bradycardia. So this is called what? Sinus bradycardia. Excellent. Next. Look at this. Okay. Now this remains the same everywhere. and then the heart rate is around, I mean, you can see the boxes are 8. So this is 38 beats per minute. The bradycardia is less than 60. So this is called sinus bradycardia. Okay. Now, this is the sinus node. Okay, that gets blocked. So what happens? What starts functioning next as a pacemaker? The AV node or the junctional node. We'll put it as whatever way. Okay. Now what will be absent here? P waves will not be absent. Fair enough? Now even below that, if you don't, the conduction is blocked, the junction, below the junction is blocked. So what will happen here? What will start firing? The Purkinje fibers or the ventricles will start firing. Okay. So keep this in mind. Let's go this. Now what is this? Next. See the last one, or you can look at the topmost one. There are 3 complexes here. Is there a QRS?
Yes, sir.
Is there a P wave?
Yes, sir.
PR interval is significantly same for both.
Yes, sir.
What is the heart rate? 7.
7.
So that is 43. 300 divided by 7 is 43. So is brady or tachy?
Brady.
Brady. What rhythm is it?
Sinus Brady.
So this is called sinus.
Brady.
Wonderful. Wonderful. Next. Next. Please get a fast. Let's not waste time. Look at the rhythm strip. Is the complexes narrow? Narrow or wide? QRS is narrow or wide?
Narrow.
Narrow. Do you find a P wave there?
Absent.
No P waves are there. So that means sinus rhythm is not there. Right. Now look at the, how many boxes are there? 7. Let's keep it as 7. So what is the rate?
43.
43. Brady or tachy?
Brady.
So what is this?
Supraventricular.
Supraventricle rhythm is a rhythm. So the sinus node is blocked. So we can tell AV node is functioning now. So we can tell this functional AV nodal escape rhythm or junctional escape rhythm. So this is an escape. Okay. So now the pacemaker is formed by the junction, either the AV node or the bundle of this. So this is called junctional escape rhythm. The AV node is not functioning. The QRS complex is still narrow, no P wave, so this is called junctional escape rhythm. Next. Is this brady or tachy?
Brady.
Brady. I will tell you, 12 boxes. So 12 divided by 300 divided by 12 is max 25. Okay, so it is 25. Brady or tachy?
Brady.
Okay. How are the complexes? Narrow or broad?
Broad.
Broad. Do you have a P wave anywhere?
No.
No. So if you have a sinus bradycardia, P wave should be there. If it is a junctional escape rhythm, the QRS complex should be
Narrow.
narrow. Keep it close to your mouth.
Narrow.
If it is below the AV node or the bundle of his, then the QRS complexes will be
Broad.
broad. So this is called what? Ventricular
Brady.
escape rhythm. Okay. So this is a ventricular escape rhythm. Okay, which is a bradycardia. As simple as that. You are clear. So we found three rhythms. One is sinus bradycardia, junctional escape rhythm, and ventricular escape rhythm. Clear? Fine. Next. Look at the rhythm strip. Look at the lowermost panel. QRS is narrow or wide?
Narrow, sir.
Narrow. It is preceded by a P wave or not?
Yes, sir.
So P and QRS are in harmony.
Yes.
Now what is the rate?
Divide
3.5 boxes?
100, sir.
300 box, 3.5. So it is between 75 and 100. Let us say 85. It is
Bradycardia.
tachycardia or bradycardia?
Bradycardia.
60 to less than 60 is brady. More than 100 is tachy. This is 85. So what is it? Normal rate. So what is this rhythm? Normal sinus rhythm with a normal heart rate. Fair enough? Next. Next. Look at the rhythm strip, lowermost strip. Okay? QRS complex is narrow or broad?
Narrow, sir.
Narrow. Is it preceded by a P wave?
Yes, sir.
Regularly P and QRS interval are normal.
Yes, sir.
Yes, sir. Now what is the number of boxes between the two R waves?
2 boxes.
2 boxes. So what is the rate?
150.
150. Tachy or brady?
Tachycardia.
Tachycardia. Sinus
Sinus.
rhythm.
tachycardia.
What is the rate?
150.
Tachycardia. So what do you call that?
Tachycardia.
Sinus tachycardia. Fair enough? Right. Next. QRS complex is narrow or broad?
Narrow.
Preceded by a P wave or not?
Yes.
PR interval constant.
Yes.
So what is the, how many boxes are there?
2.5.
Less than 3. So 2.5 boxes. So what is it?
175. 120.
It's around 125. Okay, it's 120. Is it tachy or brady?
Tachycardia.
What is the rhythm?
Sinus
So what is it called? Sinus?
tachycardia.
Wonderful. Next. Fast. Lower rhythm. QRS is narrow or broad?
Narrow, sir.
Narrow QRS. Preceded by a P wave.
P wave, yes, sir.
PR interval is
Constant.
static.
Yes,
Constant.
sir. Yes, sir.
What is the rate?
120. Again, 2.5.
2.5. So 1 second it is around 125.
120.
So what is this called? Sinus?
Sinus tachycardia.
Louder?
Sinus tachycardia.
Wonderful. Next. Okay, look at the rate alone. 2 boxes. Let us say 2 boxes. Look at the rhythm stick. 150. So it is tachycardia. Complexes are narrow or broad?
Narrow.
Narrow complex. Do you have a P wave here?
No, sir.
So what is it called? So what is the rhythm?
Supraventricular.
Supraventricular rhythm plus tachycardia. It is called supraventricular
escape.
Die.
Tachycardia.
Tachycardia. So it's called supraventricular
Tachycardia.
tachycardia. So this is called supraventricular tachycardia, SVT. Perfect. Wonderful. This is how a supraventricular tachycardia looks like. You have an abnormal foci just above and around the AV node, not from the SA node, beating at a faster rate, and then you get the complexes. You hardly see the P waves, and the QRS complexes are narrow. Koncham volume coming. Okay, so that's the genesis how an SVT is generated. Okay, next. Look at the lowermost part, rhythm strip. What is the heart rate?
To 150.
150. Tachy or brady?
Tachy.
Narrow complex, broad complex QRS.
Narrow complex.
Is it preceded by a P wave?
No.
No P wave. So what is this called?
Supraventricular
Supraventricular
tachycardia.
Wonderful. Next. Fast. Come on. Rhythm strip. What is the rate? Let us say 2 boxes. So what is the rate?
150.
Is it tachy or brady?
Tachy.
It is narrow complex, broad complex.
Broad. Narrow.
Is it preceded by a P wave or not?
No.
So what is this called?
Supraventricular tachycardia.
Supraventricular tachycardia. Excellent. Next. Look at the rhythm strip.
Yes, sir.
Okay. Narrow complex.
Yes, a narrow.
Tachycardia is there.
Tachy. Irregular, sir.
It's irregular.
Yeah.
Sometimes tachycardia, sometimes bradycardia.
Could be.
So what is this called? Narrow complex, no P waves, irregular.
Supraventricular.
What is this called? These are all called fibrillatory waves. So this is typical of atrial.
Atrial fibrillation.
Exactly. Wonderful. Okay. So this is atrial fibrillation for you. Right? So you have multiple waveforms. One of them get conducted to the ventricle. Okay. Once the refractive period gets over, one of them conduct. So it gets irregularly conducted. So you have irregular QRS complexes, and then you don't see a P wave at all. You can see small fibrillatory waves. Typical atrial fibrillation. Okay. Now, let's recoup. Okay. Sinus rhythm means what? P wave should be followed by a QRS. QRS should be narrow. PR interval should be constant. In a sinus rhythm, if the heart rate is less than 60, it is called sinus bradycardia. If the heart rate is more than 100, it is called sinus tachycardia. Now we come to another one. Okay. Sinus node is gone. Right. You have a narrow complex, no P waves. Heart rate is less than 60, it is called junctional escape rhythm. Okay. Now you have another one where you have a narrow complex, tachycardia, no P waves, regular. It is called supraventricular tachycardia. You have another one, patient has got a narrow complex, tachycardia is there, irregular. It is called atrial fibrillation. Fair enough? So we went through 5 types of ECGs in rhythm. Okay. Now next, who's got the mic? Get up. Narrow complex?
Yes, sir.
Any P waves?
No, sir.
No P waves. Regular or irregular?
Irregular, sir.
Huh? Irregular. So what is this?
Fibrillation.
Louder.
Atrial fibrillation.
Atrial fibrillation. Next. Get up fast. Participate. Look at the lower rhythm step. What is it? Narrow complex?
Yes.
Regular or regular or irregular?
Irregular.
So what is this? Narrow complex, irregular is atrial
Atrial fibrillation.
fibrillation. Wonderful. Okay. So we went through 5 rhythms. One is sinus rhythm, another is junctional rhythm. Okay. Both we had brady and tachy. Okay. In junctional we had brady and tachy. We further classified the tachy into regular and irregular. Regular is supraventricular tachycardia. Irregular is atrial fibrillation. Wonderful. Okay, next. Narrow complex or broad. Is it tachycardia?
Broad.
Broad. Is it tachycardia?
Yes.
Tachycardia. How much is the rate? It's almost 1.5. It's almost 1.5. That means it is more than
100.
more than 200. Okay, that's how the rate is. Is it narrow or broad?
Broad.
Broad. Can you see any P waves?
No, sir.
So what is this called? It's ventricular in origin, ventricular rhythm. It is tachy or brady?
Tachycardia.
So what is called? Ventricular?
Tachycardia.
Wonderful, wonderful. So this is nothing but ventricular tachycardia. Next. So this is how a ventricular tachycardia looks. Okay. So the foci or the pacemaker is situated in the ventricles, and because it is there in the ventricles, the complexes are broad. Okay. So you get broad complex tachycardia, ventricular in origin, it is called ventricular tachycardia. Next. Broad or narrow?
Broad.
P waves are seen or not?
No, sir.
So the origin of impulse is where?
Purkinje 5.
In the
Ventricles.
ventricles. Okay. Perkin. Tachycardia or bradycardia?
Tachycardia.
So what is this called?
Ventricular tachycardia.
Perfect. Wonderful. So it's called ventricular tachycardia. Next. Broad or narrow?
Broad.
P waves are seen or not?
Absent.
Tachycardia is there or not?
It's a tachycardia.
Regular or irregular?
Irregular.
So this is sign. Rhythm is ventricular in origin. Tachycardia irregular. So this is what? That we called atrial fibrillation. This is called
Ventricular fibrillation.
ventricular fibrillation. Fair enough? Fair enough? Wonderful. This is called ventricular fibrillation. Okay? This is how it looks. Multiple waveforms. Okay? Doesn't product any productive contraction of the left ventricle. So this is typically ventricular fibrillation. Okay. Now let's recoup. Okay? So first thing that we look in the rhythm is whether P waves is present and whether that is related to the QRS, whether both of them are married or not. If they are married and if it is yes, then it is sinus rhythm, and we divide, and if it is the not married and if it is narrow, it is called supraventricle, and if it is broad, it is called ventricle in origin. You are clear with this? All of you are there with me? Can I hear a louder yes? Yes, sir. So it is sinus rhythm if it is present, and if it is narrow, it is supraventricular rhythm, and if it is broad, it is called ventricular rhythm. Now sinus, we have two types. One is brady and tachy. So if the heart rate is less than 60, it is sinus bradycardia. More than 100, it is sinus tachycardia. Now we come to the narrow complexes. Once again, you have something called brady and tachy. If it is brady, then you have the no P waves, narrow QRS, bradycardia, it is junctional escape rhythm because the P waves are not conducted. Okay? When you have sorry. So you have brady, that's called junctional escape rhythm. You can have tachy, then you have regular and irregular. If it is regular, it is called supraventricular tachycardia. If it is irregular, it is called atrial fibrillation. When you have a broad complex, once again you can have a brady and a tachy. If it is brady, it is called ventricular escape rhythm, and if it is tachy, but it is regular, it is called as ventricular tachycardia. If it is irregular, it is called ventricular, louder, ventricular fibrillation. Perfect. Okay, that's how we go about with rhythm. You want a break, or we continue and finished off? People who want to continue, raise your hands. Okay, since majority of the people have raised their hands, you don't have an option. You need to raise your arms. Fair enough. We'll finish it fast. Okay, so we talked about the rate. We talked about the rhythm. Right? Give me 3 minutes break. I'll give you a 3 minutes break. Okay? Just think what we have learned till now. 3 minutes break, because the next couple of 2 more chapters are going to be really hard going through. So take a 3 minutes break and I come back to you. Okay? People who want to use the restroom, go fast and come back. Can you be seated, please? Okay, we start. Next comes the chamber hypertrophy. How many chambers are there? 4. What are they? Right atrium, left atrium, right ventricle and left ventricle. Okay, fine. Now, what is the wave that is responsible or denotes the atrial depolarization? That's a P wave. So, we need to look at P waves, right, for atrial enlargement. Now, if you remember what I said before, the first half of the P wave denotes what? Right atrial depolarization, and the second half denotes the left atrial depolarization. Fair enough? So, one half is for right atrium, one half is for the left atrium. So, I told you we will see look for P waves in 2 leads. What are the 2 leads? Lead 2 and V1. These are 2 leads that we will look for. Okay. So, let's just go through that. Now, if you look at, this is what I already told you. The first half denotes right atrial, the second half of the P wave denotes the left atrium, or you can divide into 1/3 component. First 1/3 of right atrium, middle 1/3 of both, and the left atrium, the last 1/3. Now, to be seen in lead 2, which it is monophasic, whereas in V1 it is biphasic. That is, first you have a positive, next you have a negative deflection. Don't worry about the axis. The duration is less than 120 milliseconds. That is how many small boxes? 3 small boxes. Each small box corresponds to 40 milliseconds. Perfect. And the amplitude should not be more than 2.5 millimeter in lead 2 and not more than 1.5 millimeter in V1. Okay. So, this is the basics. Now, when you have, this is what I said, when you have the right atrial depolarization waves precedes, this is what we already talked about. Now, look at this wave. This is lead 2 and lead 3. The one with the mic. Who's got the mic? Yeah. Is there a P wave? Is there a P wave?
Yes, sir. Yes, sir.
Louder?
Yes, sir.
Very nice. Now, can you tell me what is the height of the P wave? What is the lead that is showed for you? Lead
2 and 3.
2 and 3. So, in lead 2, if you look at the P wave, how tall it is?
It's
What should be the parameter? What is the cutoff? 2.5.
2.5.
Is it 2.5 or more than that?
More than 2.
It is around 3 plus. Okay. So, there is a tall P wave. Okay. Now, the understanding for this is due to right atrial depolarization. Right atrial depolarization lasts longer and it extends up to the left end of left atrial depolarization. So, both the amplitudes fall on each other. So, when 2 amplitudes fall on each other, what will happen? You get a tall P wave. So, when you have a tall P wave in lead 2, more than 2.5 millimeter in height, then it is indicative of right
atrial hypertrophy.
enlargement. Okay. Now, look at this. This is what I told you. Both the amplitudes fall in the same space, and one above the amplitude adds to the voltage and you get a taller wave. So, that is indicative of a right atrial enlargement. Now, look at this next. Please get up, make it fast. What is this? The P wave is there or not?
It's there.
Is it normal or bifid?
Bifid.
It is bifid. You have 2 peaks. Okay. Closely you look at that, it is slightly more than 3 small boxes. So, if it is more than 3 small boxes, what that does mean? It means wide P wave. Okay. So, in lead 2, if you have a wide P wave, it indicates what? Left atrial enlargement. So, if you have a tall P wave, it is right atrial enlargement. If you have a wide P wave, it is left atrial enlargement. As simple as that. Okay. Right. Now, what happens in V1? Slightly complex to understand. The position of the heart, the right atrium is in the front and the left atrium is in the back. So, once the V1 is placed over the chest anteriorly. So, the right atrium gets depolarized. So, the wave of depolarization is towards the V1. So, you get a positive wave. After that, the left atrium gets depolarized, which is away from V1. So, that's why you get the negative deflection. This is a wonderful phenomena. Why? Because you can easily separate the right atrial activity and the left atrial activity. So, if the positive things are much more prominent, then it is right atrial enlargement. If the negative things are much more prominent, it is left atrial enlargement. Okay. So, this separation of the right and the left atrial electrical forces in V1 means that abnormalities affecting each individual atria waveform can be discerned in this lead very nicely. Okay. So, to summarize the whole thing, so in V1, if the positive wave is more than 1.5, it is right atrial enlargement, and if the negative is broad and deep of 1 millimeter in depth and in width, then it is called left atrial enlargement. Summarizing the whole thing. So, in lead 2, if it is tall by more than 2.5 millimeter, it is called right atrial enlargement. If it is wide, more than 3 small boxes, it is left atrial enlargement. If in V1, if it is taller than 1.5, it is right atrial enlargement, and if it is 1 millimeter in depth and 1 millimeter in width, it is called left atrial enlargement. Fair enough? Am I clear? Okay. So, for atrial enlargement, you look for which wave? Louder. Which lead will look for? Lead 2 and V1. Okay. Now, next, who is in line? Can you see a P wave in lead 2?
Yes, sir.
Yes? Okay. So, how is it?
It's tall.
It is almost more than 3 millimeter in height. So, what is it?
Right atrial enlargement.
Now, next lead which you look for?
3.
So, you have lead, which lead you look for?
V1.
V1. So, if it is positive or negative, which should you look for right atrial enlargement?
Positive.
It should be positive. Can you see that it is very nicely positive in V1?
Yes.
So, this is indicative of a right
atrial
atrial enlargement. Next. Look at the P wave in lead 2.
Yes, sir.
What is characteristically present?
Bifid.
It is bifid. Wonderful. Now, which lead you look for next?
B1.
V1. What is there prominently? Positive or negative is prominent?
Negative.
Negative. So, what is this?
Left atrial.
Left atrial enlargement. Very nicely, you can see the RA and the left LA component getting separated. A wide P wave, a broad biphasic P waves are there. Very classical of a left atrial enlargement. And you can see the negative deflection more than 1 millimeter in depth and more than 1 millimeter in width. Very characteristic of a left atrial enlargement. Okay. So, if you have a right atrial enlargement, it is called P
Pulmonary.
pulmonale. Incorporating with your mitral stenosis and pulmonary hypertension. If you have a feature suggestive of a left atrial enlargement, it is called P mitral. You understand? Okay, perfect. Very nice. Sit down. Next, we come to the left ventricular hypertrophy. So, you look at 2 leads. One is V1. Okay, you look at the V1 and the V5 and V6. Okay, you look for S waves in V1 and the R waves in V5 and V6, or the combination of both. If you have a single S wave of more than 30 millimeter in V1 or V2, that is suggestive of left ventricular hypertrophy. Or if you have a single R wave of more than 30 millimeter in V5 and V6, that is suggestive of left ventricular hypertrophy. Or the S in V1 plus R in V5, V6 is more than 35 millimeter, it is suggestive of left ventricular hypertrophy. Simple points. I don't think so you need to be worried. Okay. If you look at the axis of the heart, V1 is placed away from the left ventricle and V6 and V5 are placed towards the left ventricle. Okay. So, if you have nice ventricular mass, the electrical force will be much more towards V5 and V6 and away from V1. You understand? So, S waves are negative waves, R waves are positive waves. So, if you have left ventricular hypertrophy, more R waves in V5 and V6, S wave in V1 and V2. You understand? Okay. Now, next with the mic. Come on. Okay. Tell me the S wave in V1. What is the depth? 3 boxes. 3 boxes means each box, large box is 5 millimeter. So, 3 boxes is
15 millimeter.
15 millimeter. Now, look at the R wave in V5. 1, 2, 3, 4, 5, 6, 7. So, 7 into 5 is 35 millimeter. So, the single criteria of R wave in V5 is more than 30 millimeter is our cutoff. Now, here it is 35. So, what is it? Left? Keep it close. Tell. No problem. Don't have to feel bad.
Left ventricular hypertrophy.
Exactly. Wonderful. Wonderful. Left ventricular enlargement. So, you have a nice positive R wave more than 30 millimeter in V5. That itself is indicative of a left ventricular hypertrophy. The S wave in V1 plus R in V5 is almost 50 millimeter. That is also indicative of a left ventricular hypertrophy. Next. Come on, take it. It's okay, we'll go through that. You come back. Look at the S wave V1. 1, 2, 3, 4, 5 and 6 or 5. 5 is what? 5 into 5 is what? 25 millimeter. Look at the R wave in V5. 1, 2, 3, 4, 5. So it's another than 25. What is it? So 25 plus 25 is? 50. So what is our cutoff? 35 millimeter. So this is what?
Left ventricular hypertrophy.
Wonderful. Next. Get up. So for right ventricular hypertrophy, once again small things. The R wave in V1 should be more than 7 millimeter, or the RS ratio should be more than 1 in V1, or the RS ratio should be less in V5 and V6. Okay, simple. 3 points. Repeat the points.
Sir, in R wave in V1 should be greater than
What than 7 millimeter,
millimeters.
or
Or
RS ratio in V1 should be more than 1, or RS ratio should be
V5 and V6
should be less than 1. Simple. 3 points. Now tell me this. Look at the R wave in V1. What is the height? It is almost 12 millimeter.
12 millimeter.
So this by itself is fulfills the criteria. What is the RS ratio? More than 1? There is no S wave in V1 at all. So it is more than 1. Look at the V5, V6. What is the RS ratio? The R waves are smaller than the S wave. So this RS ratio is less than 1. So what is it? What ventricular hypertrophy?
Right ventricular hypertrophy.
Exactly. Wonderful. Next. Come on, fast. R wave in V1.
1, 2,
Around 15 millimeter. Is it more than enough? This itself is sufficient. What else is there? RS ratio is more than 1 in V1. RS ratio in V5 and V6 is less than 1. So what is this?
right ventricular
Exactly.
hypertrophy.
Okay. So we went to the hypertrophy, the right atrium, the left atrium, the right ventricle and the left ventricle. Fair enough? Now pay attention. Anybody who answers this question will get 500 marks or 500 rupees from the organizing committee. 500 rupees. The choice is open. 500 rupees on the cards. 750 rupees on the cards. My senior professor from SRM sir has come. He has promised 1000 rupees on the cards. 1000 rupees. At least tell me something. Look at V4, V3. Both the R and the S are very, very prominent. Nice tall R waves, nice deep S waves. In V3, V4, V5. What is it indicative of? What is that? 1000 rupees. It is biventricular enlargement. Okay, the 1000 rupees gets to, I get the 1000 rupees. Sir, please give me the money when I go home. Thank you, sir. Okay, so this is typical of a biventricular enlargement, which classically happens in an VSD, in the early stages of VSD, when the child is born with a large VSD and there is biventricular enlargement. Okay, this is called Katz-Bachtel phenomena. Fair enough. Okay, now the most interesting part. Myocardial infarction. Pay attention, pay attention, pay attention. So the criteria is ST segment elevation more than 1 millimeter in 2 or more contiguous limb leads. ST segment elevation more than 2 millimeter in 2 or more contiguous chest leads. Now what are the limb leads? Limb leads are lead 1, 2, 3, AVR, AVL, AVF. More than 1 millimeter in 2 contiguous. What do you mean by contiguous? Nearby leads. Lead 2, AVF. AVF, lead 3. Lead 1, AVL. Those are all contiguous leads, nearby leads. Okay? Or more than 2 millimeter in chest leads. What are the chest leads? V1 to V6 are chest leads. Fair enough? This is the criteria. Okay. Now, we divide based on the location into anterior wall, inferior wall, lateral wall, posterior wall and right ventricular infarction. Okay? Now, we're going to go through this fast. Right. Now, this is a topographic arrangement. I told you the limb leads represents the heart in what plane? Vertical plane. Okay? Now, the chest leads represents the heart in the transverse or the horizontal plane. Now, mix it up and then what you get is this type of this. V1 and V2 is louder. Louder. Septum. V3 and V4 is Louder. V5 and V6 is apical or low lateral. Lead 1 and AVL is louder. Louder. 2-3 AVF is inferior. 2-3 AVF is, please understand, next couple of slides depends upon this one simple slide. Okay. Now, one more thing. What did we say? Now, we can also put some more leads and try to localize the infarct. For example, you can put, instead of the left side, you can put on the right side, and those are called right-sided leads to diagnose right ventricular infarct. You can also put them on the back, right? V7, V8, V9, and to find out posterior infarcts also. These are all things that we can play with the leads. Okay. Now, we should know that the LAD supplies the anterior free wall, anterior part and the apex. The LCX supplies the lateral wall, and the RCA large part of the inferior surface of the left ventricle, posterior wall of the left ventricle and the right ventricle. Please keep this in mind. Okay. The RCA supplies what? Inferior, posterior and the RV. The LAD supplies the anterior septum, anterior and apex of the LV. The left circumflex supplies the lateral aspect of the LV. Keep this in mind. Fair enough? Okay. Now we said this. ST segment is compared to which segment? TP segment. Please understand, this is the basis of your ST elevation and depression. So ST segment depression or elevation is compared to this component, which is the TP segment. This is the TP segment. Please understand that. Okay. Now let's start. Next, who is on cards? Get up. Is there an ST segment elevation anywhere?
In V2.
See, I told you anterior wall. Okay. So anterior wall means what? We have some 6 leads. V1 and V2 is
Septal.
septum. V3 and V4 is
Anterior.
anterior. V5 and V6 is
Inferior.
apical or low lateral.
lateral.
Now concentrate. Is there an elevation?
In V2.
Be louder, closer and louder and faster.
In V2, V3.
ST elevation in
V2.
V2,
V3.
V3, a bit in
V1.
V1 and
V4.
V4. V1 and V2 corresponds to
Septal.
V3 and V4 corresponds to.
Anterior.
So this is what?
Anteroseptal.
Anteroseptal acute myocardial infarction. Complete it.
Anteroseptal acute myocardial infarction.
Perfect. Wonderful. Next. Next. Fast, fast. Come on. Give it to the front. Give it to the front. Give it to the front. Keep moving. Please get up. Come on. Okay. Is there an ST segment elevation?
Yes.
Yes or no?
Yes, sir.
Which leads? This is what?
V2,
V2,
V3,
V3,
V4.
V4. Okay. So V1, V2 is what?
Septal.
V3 and V4 is what? So what is this? Acute anteroseptal myocardial infarction. Next. Keep moving, please. Get up. Is there an ST segment elevation anywhere?
Yes, sir.
Where is it?
V3.
V?
3.
This is?
V4 and V5, V6.
V3 and V4 corresponds to?
Anterior.
V5 and V6 corresponds to?
Lower lateral.
Low lateral. So this is an what?
Anterior, lower lateral.
Anterolateral
Anterolateral.
acute myocardial infarction. Fair enough? Next. Next. Come on. Hey, the guy, give it to the guy next. Give it to the guy next to you. Come on, get up. Now tell me, where is the ST elevation?
V1,
Ah,
V2
ah,
and V3.
and
V4 also, yeah.
ah,
V5,
ah.
V6 also.
V6 also. So
Ah,
what is this?
okay.
V1 and V2 is?
Septal,
3 and 4 is?
anterior,
V5 and V6?
lower lateral.
So low lateral or apical. So this is an extensive anterior wall MI. Okay, you understand?
Yes.
Perfect. Next. Come on. Okay. Now look at this here. This thing. Is there an ST elevation anywhere?
V1,
Lead 1 and?
lead 2,
And?
AVL,
So what is this? Lead 1, lead AVL is there. So what is this?
septal,
Lead 1 and AVL.
lateral,
High
lateral.
lateral MI. Perfect. Next. Next. What is this? Is there an ST segment elevation anywhere?
Yes, sir.
Is there or not?
Yes, sir.
Where is it?
Lead 1,
Lead 1 and?
AVL.
So what is this?
High lateral.
High lateral MI. Acute myocardial infarction, high lateral is the localization. Perfect. Next. Look carefully. I'll give you some clue. V3, V4, V5, V6.
Yes, sir. There's an ST elevation in V3, V4.
No, in V3. I
V4.
mark V4
V5
and V6.
V6.
So what is this? Predominantly low lateral or apical infarct.
Apical.
Perfect.
Yes.
So please understand, if it is V1 and V2 it is septum, V3 and V4 it is anterior, V5 and V6 is apical or low lateral. Lead 1 and AVL is high lateral MI. Perfect. Next. Next. What is this? Is there an ST segment elevation? Yes or no? Keep close to the mouth.
Yes, sir.
Where all? Where all?
2,
Two,
3,
Three.
AVF.
So what is this? 2, 3 AVF is?
Inferior.
So this is what? Acute myocardial infarction. Localization is
Inferior.
inferior wall MI. Next. Come on, fast. Is there an ST segment elevation?
2,
2,
3,
3.
AVF.
So what is that? Territory.
Acute inferior wall MI.
Acute inferior MI. Wonderful. Okay, next. Now, inferior wall is supplied by what? They are telling something. You can get the answer. Inferior wall is supplied by the
right coronary.
right coronary artery. Right coronary also supplies what? Two more structures. What is they? Posterior wall and right ventricle. Okay. So whenever you get an inferior wall MI, you need to find out whether there is an association posterior wall or right ventricle. Perfect. Okay. Now answer me. Is there an inferior wall? Is there elevation in 2, 3 AVF?
Yes, sir.
Yes. Okay. Now, I told you in the beginning slightly some slides before to find out posterior wall, what will you put? Where will you put the leads?
Scapula.
Behind the scapula. To find out right ventricle, where you will put the leads?
Right side.
Right side. Wonderful. So inferior wall MI is associated with, can be associated with right ventricle or posterior. So if you want to put a posterior, you want to find out whether posterior wall MI is there, where will you put the leads?
Behind the scapula.
You will put in the scapula. Okay, I will put it in the scapula. Okay. Now V7, V8 and V1. Okay. Now look at this. Now there's an elevation in V7, V8 and V9. So what does it indicate you of?
Posterior wall.
Posterior wall MI. Now you go back. This is V7, V8. You will have an elevation. This is opposite side leads. So what will you have here?
Depression of
ST depression. Perfect. So you did not have to put the V7, V8 and V9. If you see ST depression in V1 and V2 which is opposite, that is indicative of
posterior wall MI.
Exactly. Wonderful, man. Wonderful. Okay. Now this is what I did. I changed the leads V7, V8 from 4, V5 and V6. I changed into 7, 8, 9. Is there an elevation there?
Yes, sir.
So what is it indicative of?
Posterior wall MI.
RV plus posterior wall. And what happens to V1 and V2? What is there?
ST depression.
ST depression. Okay. So it's a wonderful example of an inferior wall MI plus
posterior wall.
Beautiful. Beautiful. Next. Is there an inferior wall MI?
Yes, sir.
Can you find anything else?
Posterior wall MI.
Where, why do you say that?
V1, V2, ST depression is there.
ST depression and V1 1. Wonderful, ma. Beautiful. Beautiful. So this is an inferior wall MI plus posterior wall MI. Beautiful. Next. Is there an inferior wall MI? 2, 3 AVF. Is there an ST elevation?
Yes, yes.
Yes. So this is inferior wall MI. Now, there is no ST depression in V1 and V2. So there is no posterior wall. Would you like to put the lead somewhere to find out something else? What else you can get in inferior wall MI? Right?
Right.
Ventricle can be involved. So you put on right sided leads. Okay. Now I put a right sided lead. Okay. Now what did I get? This is the first ECG. After I change this RV4 alone, what is there now? ST? What is an RV4 now?
Depression.
Hey, look at here this leads which I am circling.
Elevation. Elevation.
Elevation. So this is an inferior wall MI. I put an RV for right sided leads. There also elevation is there. So this is inferior wall MI plus right ventricle MI. Be louder.
Right ventricle.
Right ventricular MI. Perfect. Next. Get up. Is there an inferior wall MI?
Yes, sir.
That's an inferior. So here I have changed the leads. RV4 I have put right sided lead. So is there an elevation there?
Yes, sir.
So what does it mean?
Sir, inferior wall MI.
Inferior wall MI plus
Right ventricle.
right ventricle. Next. Is there an inferior wall?
Yes, sir. 2, 3 and AVF is
Yes. What is there here? I have changed the leads.
right ventricle.
So right sided leads I put. Is there an elevation there?
Yes, sir.
So what is it?
Right
inferior
ventricular.
wall plus
Right ventricular.
perfect. Okay. So please keep in mind, whenever you have a right ventricle infarct, you need to find out whether there's a posterior wall MI. In an ECG, you don't have to put leads. V1 and V2 will have depression. Okay. If you want to find out right ventricle infarct, you just have to change the lead to this side, and then you will find an ST elevation. If it is there, it is indicative of a right ventricle MI. So we saw the whole ACS in slight bird's eye view. Left anterior descending artery territory, you have infarcts, 3 types of infarcts. Septum, next is anterior and apical. V1 and V2 corresponds to louder. V3 and V4 corresponds to anterior. V5 corresponds to apical. Left circumflex territory is the lateral. So if lead 1 and AVL is infarcted, what is it indicates? High lateral infarct. Okay. V5 and V6 alone is infarcted, it's called low lateral or apical infarct. For to tell it is inferior wall MI, where you should have ST elevation? 2, 3 and AVF. All inferior wall MI, you should rule out 2 things, 2 extra things. What are they? Posterior and right ventricle. For posterior, where will you look for? V1 and V2 ST depression. For right side, what lead you will put extra? Right side leads RV4. You understand? Okay? Perfect. So the last part is the ischemia. T-wave inversions are suggestive of the possibility of ischemia. ST segment depression is indicative of definite ischemia. Okay? Next, please take the mic. Is there ST segment depression anywhere?
V4.
V4?
V5.
V5?
V6.
V6 and?
V3.
And?
V2.
V2. So what is this? ST segment depression is definitive of ischemia. So what do you call this? V1, V2, V3, V4, V5, V6. Extensive, anterior wall, definite ischemia. Next. ST depression
In
ST depression?
Lead 3.
Lead 3?
AVF.
AVF. So what is that territory?
Inferior.
So this is what? Inferior wall?
Definite
ischemia. Perfect. Next. ST depression in?
V2,
V2,
V3, V4, V5.
V5. So what is this?
Anterior wall.
Anterior wall. Definite?
Ischemia.
Definite? Tell.
Ischemia.
Definite ischemia. Next. Is there ST segment depression anywhere?
V3.
Lead 3.
V4.
Lead 3 and? I am rounding da, circling da.
AVF.
AVF and?
2.
So this is which territory?
Inferior wall.
Inferior wall. So this is inferior wall?
Definitive
ischemia. Perfect. Next. Is there ST segment or only T-wave inversions?
T-wave.
Where? T-waves are this da. So T-wave inversions in?
V4.
V4?
V5.
And?
V6.
So what is this? Only T-wave inversions. What is this?
Possibility
of ischemia. Perfect. Next.
Sir.
T-wave inversions are there. Where?
2, 3.
2, 3 and AVF. So what is this?
Possible ischemia.
Possibility of a inferior wall ischemia. Perfect. Okay. I am done. Okay. So please remember, I stop here, but you don't stop here, right? ECG is such a volatile thing. The minute you go outside and go to the toilet and restroom and come, it's done. Right? It gets fast in, gets fast out. So you need to go back, okay? You're all fertile minds, not corrupted minds like us. So you are all fertile people. So you can imbibe things much more faster, okay? So every week at least you take 2 ECGs. Just go through the 5 points that we talked. The rate, the rhythm, hypertrophy, ischemia, infarction. Just try to find out, okay? And if you look at your Davidson, all this interpretation will be given lower down itself, okay? Just 2 ECGs every week, and that will keep you moving. That will keep you get interested. And this is something which you can correlate clinically also as you become a CRRI and doctors in future, okay? Thank you all for your patient listening. That was a wonderful session. Thank you so much. Thank you so much. Thank you so much. Thank you, sir, for this wonderful opportunity. Thank you so much. Indebted to you.